A warm welcome everyone. Today we are going to see a topic related to cardiac pathology. Let's move into the topic. The topic we are going to discuss today is the infective endocarditis. You can expect 15 marks and 5 marks from infective endocarditis in the university exam point of view, and also it's a quite important topic in the entrance exam. So let's discuss briefly into this topic. Let me give you a brief introduction. As the name suggests, infective endocarditis, which means infection occurred. Infection is caused by microbes. So there will be microbial infection of the heart valves or the mural endocardium. There will be vegetation formation. What are vegetations? These are masses which consist of fibrins and other debris materials. Here there will be thrombotic debris and organisms. There will be destruction of the underlying cardiac tissues. The vessels affected here are the aorta, and other blood vessels like superior vena cava, inferior vena cava, and prosthetic devices. What are prosthetic devices? These are replaced cardiac valve through surgery. So these are also affected and become infected. Now coming to the causative agents, there are many causative agents for endocarditis. They are bacteria, virus, fungi, parasites, etc. etc. But the most common causative agent is the bacteria. So bacterial endocarditis is most common. And there can also be fungi endocarditis and other classes of microorganisms. We can diagnose this endocarditis, and identification of this agent, causative agent, is very important for effective treatment to reduce morbidity and mortality. Now let's move on to the types of endocarditis. It is subacute and acute. In subacute, there will be insidious onset, which means rapid onset, and it affects deformed valves only. In acute, it affects previously normal heart valve. Here the causative organisms of low virulence, that is examples Streptococcus viridans, and here the causative organism is of high virulence, that is Staph aureus. Here there will be less destruction and here there will be more destruction. Here you can see microscopically granulation tissue, which suggests that it is of indicating of healing. With time, fibrosis occurs, calcification occurs, and chronic inflammatory infiltrate also develop. It is enough to treat it with antibiotics itself, but antibiotics will not work here. Here it requires surgery. The morbidity and mortality here it's low, but morbidity and mortality here it's high. As I said you before, the most common reason for infective endocarditis is the microbial infection. The most common valves that are affected are the abnormal valves. What? The most common valves that are affected are the abnormal valves. The abnormalities in the valves include mitral valve prolapse, degenerative calcific valvular stenosis, bicuspid aortic valve, artificial valves, that is the prosthetic valves, congenital defects like the ventricular septal defect, and rheumatic heart disease. But rheumatic heart disease causing infective endocarditis is less common. As we discussed before, the most common reason for infective endocarditis is the microorganism infection. The most common microorganism which causes infective endocarditis is the Staph aureus, which is a most virulent causing infective endocarditis. It is commonly found on the skin of human body, that is, it is a commensal of skin of human body. When skin breach happens, it enters into the body and causes infection. It can infect either healthy or deformed valves. It is responsible for noted 20% to 30% of cases of infective endocarditis. Staph aureus is the major causative of infective endocarditis among IV drug users. The curative rate for infective endocarditis due to Staph aureus is 60% to 90%. Now the next organism is the Streptococcus viridans. It is a normal component of the oral flora, that is, it's a commensal of the oral cavity. Due to breach in oral cavity due to some dental procedures causes the entry of this organism into the human body. It causes endocarditis of previously damaged or abnormal valves. I have said some abnormal valvular conditions where it causes infective endocarditis. It is responsible for 50% to 60% of cases, and the cure rate is 98%, which is higher than that of the Streptococcus aureus. As I said you before, it is responsible for a type of infective endocarditis. What is that type? Yes, the subacute type. The subacute type. Now the other bacterial causes causing infective endocarditis are the enterococci infection, HAG group. Comment in the comment section what are the HAG group organism. Rarely gram-negative bacilli and fungi also causes infective endocarditis, but note that half of the patient die due to infection due to gram-negative bacilli and fungi. The prosthetic valve endocarditis, that is the endocarditis due to artificial valve implantation. It is caused by our skin flora, the staph aureus and the staph epidermis. It occurs in 1 to 2 months after surgical implantation, and if it occurs 1 year after, then there is involvement of streptococci and also sometimes staph aureus also. The cure rate here is worse. Valve replacement is the only remedy. Now, the source of infection. Some of them we have discussed before itself. The bacteremia and septicemia, a dental or surgical procedure causing breach in the mucosa, causing entry of organism and causing infection. A contaminated needle shared by the IV drug abuser. A breach in the epithelial barriers of gut, oral cavity or skin due to conditions like ulcer and other conditions. But infection because of these organisms can be lowered by antibiotic prophylaxis. Now looking into the morphology, the hallmark of infective endocarditis is the vegetations on the valves of heart. Vegetations can be single or multiple. The lesions, that is the vegetations, contain fibrin, inflammatory cells like neutrophils and other leukocytes, and bacteria and other organisms. Most commonly affected site is the valves. The most commonly affected valves are the aortic and the mitral valves. The infection on the valves of right heart may be seen in the intravenous drug abusers, and there may be involvement of more than one valve. They produce a characteristic abscess in the myocardium known as the ring abscess. This is the characteristic lesion found on the myocardium, the ring abscess, as indicated by the arrow. Now, the vegetations which we saw are capable of embolization, that is, they can separate from their site of origin and they can travel and lodge in other site. These emboli fragments contains virulent organisms, that is the staph aureus. They causes abscess development where they lodge, and septic infarcts and mycotic aneurysm are also seen. This is the image of myocardic aneurysm, a rare complication of infective endocarditis as indicated by the arrow. It can lead to complications like the hemiparesis. Now coming to the clinical features, there will be rapid onset of fever, chills and weakness. In case of older adults, there will also be fever, but the fever will be slight or absent sometimes. There can also be fatigue, flu-like symptoms like headache, allergic reactions, runny nose, etc. And there will also be weight loss. In patients with left-sided infective endocarditis, you can note murmurs on auscultation. In case of long-standing infective endocarditis, you can see for microthromboemboli. It can manifest as splinter hemorrhage or subungual hemorrhages. As you see in this picture, hemorrhages are noted on the nail beds. The characteristic lesions that you notice here are the Janvey lesions. It's also a long-standing complication of the infective endocarditis. There will be erythematous, hemorrhagic, non-tender. These are non-tender lesions on the palms or soles. Now, Osler's notes, these are also long-standing lesions in infective endocarditis. They manifest as subcutaneous nodules on the pulp of the digits. Now, the last long-standing lesion of infective endocarditis is the rod spots. These are retinal hemorrhages in the eye. The picture viewed in front of you is a view of the eye through an ophthalmoscope. Now, coming to the diagnosis, we can diagnose infective endocarditis through two criteria. These are the pathologic criteria and the clinical criteria. In pathologic criteria, we can demonstrate the microorganisms through culture or histologic examination or through embolus from a vegetation or through intracardiac abscess. In clinical criteria, there are two types of criteria, major criteria, minor criteria. In major criteria, the blood culture is positive for characteristic organism like the Staph aureus or the Streptococci viridans. Or there will be continuous positivity for the unusual organism like the gram-negative bacilli or the fungi. In echocardiograph, you can identify valve or implant related oscillating mass or abscess or partial separation of the artificial valve. We can also see valvular regurgitation also. Now coming to the minor criteria, we need to elicit history about predisposing heart condition, and also we need to know about whether the person is a IV drug abuser and whether the person is suffering from fever more than 30 degrees Celsius. Vascular features include aneurysm and hemorrhage, and immunological features include glomerulonephritis. Microbiologic feature include single culture positive for an unusual organism. And we also should see about osseous node, Roth spots and Janeway lesions. Now at last, complications. There will be glomerular antibody complex deposition which will lead to glomerulonephritis and sepsis. There will also be arrhythmias and will also be systemic embolization and abscess formation in the ring of the valves and then in the myocardium. If it's left untreated, it is very fatal and deadly, can cause the patient's life. On long-term treatment with antibiotic therapy, that is 6 weeks or more time, or valve replacement, mortality can be reduced here. Now coming to the treatment part, the treatment here is based upon empirical treatment where the doctor prescribes medicines based upon patient symptoms. In case of subacute, which is harmless, we can wait until culture results come. And if it's considered, then we can give amoxicillin tablet. Remember the dosage and the route of given. In case of acute, which is a harmful type, we can give vancomycin and gentamicin. In case of a prosthetic valve endocarditis, we can give vancomycin, gentamicin, rifampicin. I am again saying, remember the dosage and route of given. We have completed infective endocarditis. Now we can see non-bacterial thrombotic endocarditis. That is endocarditis caused without the involvement of bacteria. It is characterized by a sterile thrombi, which means there will be no bacteria found in this thrombi on the leaflets of the cardiac valves. This condition usually occurs on previously normal valve. Only normal valve are affected. The vegetations are loosely attached to the underlying valve and the vegetations are non-destructive. They do not elicit any inflammatory reaction. We cannot see any inflammatory reaction over this non-bacterial thrombotic endocarditis. And embolization may occur, which may cause infarcts in the brain and heart and other organs. Non-bacterial thrombotic endocarditis is seen in patients who are cancerous, that is affected with cancer. The most common cancer here is the mucinous adenocarcinomas and also sepsis affected patient and hypercoagulable states like the malignancy, pregnancy, DIC. What is DIC? Disseminated intravascular coagulation. But the usual precursor here is the DIC. And in hyperestrogenic states where there will be use of oral contraceptive, which is a hyperestrogenic state. And endocardial trauma while using a catheter. The catheter may injure and cause non-bacterial thrombotic endocarditis. Now let's see about the endocarditis of systemic lupus erythematosus. It is also known as the Libman-Sachs disease. Here the lesions will be small. The size varies from 1 to 4 millimeter. There will be sterile vegetations where there will be presence of no bacteria, as it is seen in the non-bacterial thrombotic endocarditis. It's a consequence of immune complex deposition, that is antigen antibody complex deposition with activation of complement recruitment of Fc receptor bearing cells. Histologically, you can see inflammation of the valve, which is known as the valvulitis. There will be fibroid necrosis of the valves. The vegetations here can occur anywhere on the valve surface, that is on the caudate tendinae. They may also occur in the atrial or ventricular endocardium. There may be persistent injury due to the antigen antibody reaction and the deposition of the immune complex, since it's an endocardium in the autoimmune disorder SLE, that is systemic lupus erythematosus, and it is analogous to that seen in the rheumatic heart disease. You can see similar lesions in the antiphospholipid antibody syndrome also. With that, we have completed the topic of infective endocarditis. If you find this video informative, share this video, like this video, and subscribe to our channel Medical Defosa and press the bell icon so that you'll be getting updated. So until that, thank you.